Everyone, my name is Vicente Liz. I'm the president of the New York County Psychiatric Society, and I welcome you here tonight. Racism has been the fabric within which this country's history has been woven through the needles of slavery and segregation, educational, employment, housing, and health inequities, and purposeful silencing and disenfranchisement of Black Americans. Violence has always been the most visible method of oppression, but it is the oppression that comes with silence and passivity that most of us are blatantly complicit with and guilty of. Remaining silent is as violent as suffocating George Floyd or shooting Jacob Blake. In June of this year, NYCPS held a town hall on systemic racism and healthcare inequities hosted by our Minority Affairs, P-Force, and Residents Committee. That event spurred important conversations for our society and our members, but it also helped remind us that tackling racism takes time and ongoing hard work, and it's not something that can be covered in one sole event. From that realization, our new monthly series was born, Dismantling Racism, Building Anti-Racist Psychiatrists. Our goal is to bring awareness, education, reflection, and help our community to create empathy and actively build anti-racist psychiatrists. To break down racist systems that are in place, we all need to do our part. We're committed to building a better, more engaged community of anti-racist allies, starting with all of us here tonight. So I want to welcome you again and thank you for joining us as we figure this out together. I also want to point out that we intend for this to be a safe space to point to everyone to collectively share the complex thoughts and emotions surrounding these topics and brainstorm ways we can come together to support each other, colleagues, patients, and the community at large. These are sensitive topics, but we want everyone to be able to share openly. Tonight is our first installment of the series, and we hope you'll check out our other scheduled speakers over the coming months on our website. I want to thank the following members for their work in putting together these series: Megan O'Toole, Allison Kozolina, Anna Kostakis, Stephanie Joseph, Daniel Kushner, Asha Martin, Chanel Ramsubik, Mary Rockus, and Joa Smalls-Mantee. And now, I'd like to turn it over to Dr. Danielle Kushner, NYCPS President-elect, to introduce our inaugural speaker.
Thank you, Dr. Liz, for the honor of introducing our esteemed speaker. Dr. Cheryl Wills is a Director of Child and Adolescent Forensic Psychiatric Services at University Hospitals of Cleveland and Associate Professor of Psychiatry at Case Western Reserve University. Her interests include community and correctional psychiatry. She has consulted to the U.S. Department of Justice, Southern Center for Human Rights, and other human rights organizations to improve psychiatric care and service delivery to youths and adults who are disproportionately racially and ethnic minorities and confined in jails and prisons. She currently serves on the Board of Trustees of the American Psychiatric Association and has recently been appointed the chair of the APA's task force to address structural racism throughout psychiatry. Additionally, she has been appointed to serve on the Finance and Budget Committee by 3 consecutive APA presidents and has co-authored treatment guidelines with the APA Guideline Writing Group. She is a member of the American Academy of Psychiatry and Law and has previously represented the organization in the APA Assembly. Also, she serves on the editorial board of the Journal of the American Academy of Psychiatry and the Law. Her publications focus on forensic and clinical aspects of psychiatric practice. Today, Dr. Wills will be kicking off our Dismantling Racism series, talking about structural racism and equity in psychiatry. Please join me in welcoming her. Thank you.
Thank you. It's a pleasure to be here. And can we share screen, or how's this going to work? Or you can move the slides. It's up to you.
You should be able to share your screen.
Okay, let's see. Okay, if this doesn't work, then I'll ask you to pick up because sometimes I lose track. Can you see the slide?
Yes.
Hello?
Yes,
Okay.
we can.
Okay, I'm going to talk about structural racism and equity in psychiatry. And there are many, I could talk about this topic for a lifetime because there's so many different aspects of it. But seeing as this is the New York County Psychiatric Society, and I'm representing the APA also, I thought I'd talk about two main topics. Give you a background of how structural racism has affected us throughout the generations, and then look at what the APA is doing. So we're looking at policy, structure, organizations, and what can be done differently. So since this is New York City, and I grew up in Brooklyn and spent a good part of my weekends in Harlem where I had family members, I'll tell you about my first experience with racism, even though I did not know what it was. We moved to a house. My dad wasn't able to get a mortgage until his boss co-signed, which mortgage discrimination has been an issue that is related to structural racism in society. And when we moved there, we didn't get the house we wanted. My parents wanted. They fell in love with the house. They showed us. We all thought we were going to live there. And then as they were a couple of days before closing, they were told that by the realtor that the sale fell through because the owner knew that he had to rent to a black family but preferred a lighter skinned black family because it increased the likelihood that he could maintain friendships with his neighbors because he really liked them, even though he had to leave and he knew they would eventually be leaving. So we're living in this house, and a couple of doors down, there was a young lady named Elizabeth, and she kind of looked like Cindy Brady in the Brady Bunch. And she and my elder sister, she's 2 years older, were the same age, and we would go over there to play, or she would come to our house to play. Now, Elizabeth was white, and we were black. And Elizabeth had an older brother named Harold, and she said he was a genius, and he would tell her things about race. So she did not want to play with me because I was darker complected than my sister. And I would go to my mom, and I would just say they wouldn't let me play. And my mother said, well, if you can't play, then your sister couldn't play. And this happened quite a lot. And through the time, in retrospect, there were things said like my brother Harold, Elizabeth said, my brother Harold, he's a genius. And he says, if you got to play with a darkie, you find the lightest one you can. I never told my parents. And the tensions kept going on, and we'd play a little bit, and she'd always start out with, you can't play, and we went through this ritual. And then one day, she shoved me down the steps in my house. And I told my mom, she pushed me. And she told my mother it didn't happen. And then she said, you know, you shouldn't be surprised that she fell down because she's a darkie, and darkies do stupid things like that. Well, that was the last time Elizabeth was in our house. Now, when she made all those comments about being darker than my sister, to me, as a 5-year-old, it didn't really matter because my dad was a big James Brown fan, and in the house, we heard, say it loud, I'm black and I'm proud. But as I matured, I learned more things about the implications of these subtleties and direct, and how this affected the bigger world and my role in it. As I advanced through it, my parents tried to shield me from that to the extent possible, but like with any child, there comes a time when you start to deal with reality. Fortunately, I had the sense of pride where my dad would make it a point to stay up as late as night if he had to get African-American dolls for us and teach us pride in who we are. Not everybody is so fortunate. Both of my parents came from the South and were subjected to segregation at earlier points in their lives. Their perspectives changed when they moved to New York City during their latency ages. So when we look at structural racism and equity in psychiatry, we have some objectives here. And we're going to explain the relationship between structural racism and health disparities. And we all have different ideas. I'm just going to touch on that because some of you probably have more expertise in this area than I do. Discuss how APA is addressing structural racism, and just have some discussions probably towards the end about how to address structural racism in everyday practice. And we're going to look at the gap of how intrinsic and extrinsic biases in medicine affect health disparities and workforce diversity. And this is a quote I really like from Eleanor Roosevelt. Great minds discuss ideas, average minds discuss events, and small minds discuss people. And in this political climate, the 21st century, as we are approaching election, this has a particular resonance. It just keeps coming up in my mind, so I thought I'd share it with you. Now, I'm going to talk with you about the U.S. Constitution, or rather, I'm going to let Barbara Jordan, Senator Barbara Jordan, talk with you about Representative Barbara Jordan of Texas, the late representative, talk with you about her perceptions of the Constitution and discrimination. And she was the first African American congressman to serve from Texas in the United States House of Representatives. And she was one of the junior people selected to speak at the Watergate hearings. So here's something that she said in 1974.
Mr. Chairman, you are a strong man, and it has not been easy, but we have tried as best we can to give you as much assistance as possible. Earlier today, we heard the beginning of the preamble to the Constitution of the United States. We the people. It's a very eloquent beginning. But when that document was completed on the 17th of September in 1787, I was not included in that we the people. I felt somehow for many years that George Washington and Alexander Hamilton just left me out by mistake. But through the process of amendment, interpretation, and court decision, I have finally been included in we the people. Today I am an inquisitor, and hyperbole would not be fictional and would not overstate the solemnness that I feel right now. My faith in the Constitution is whole, it is complete, it is total. And I am not going to sit here and be an idle spectator to the diminution, the subversion, the destruction of the Constitution.
Okay, here's a fun fact. She was trained in debate by the same person under whom Martin Luther King Jr. Studied debate and oratorical skills, and Denzel Washington in The Great Debater, for The Great Debaters. Dr. Friedman, who was a professor in Texas and a nationally renowned debate coach, happens to be the father of APA member C. Friedman, who served under the Investment and Oversight Committee with me. Now, Barbara Jordan talks about we the people, and when she says that, she's not only referring to Black people, she's also referring to women. And as she says, through interpretation, amendment, and court decision, she became part of we the people. So let's take a quick look at that. Okay, Civil War occurred in the United States in 1861 through 1865, and that was the war, the North versus the South, and as we know, the North won. And then Congress enacted several amendments to the Constitution, known as the Civil War Amendments, in the next 5 years. The 13th Amendment abolished slavery, 14th Amendment made slaves citizens, and the 15th Amendment outlawed voting discrimination. However, when they outlawed voting discrimination, they did not put anything in that amendment to describe or give direction about enforcement. So there was a Civil Rights Enforcement Act, known as the KKK Act, that gave citizens every right to vote and all other rights that were they were entitled to by the Constitution. But as we know, lynching, poll taxes, literacy tests, and Jim Crow also played in a role in how that was enforced and whether or not people were able to vote. As a matter of fact, Condoleezza Rice, back then, Democrats and Republicans were kind of flip-flopped in their philosophy. So what we think of more now as Democrats was more the Republican, and more Republican is Democrat. Well, Condoleezza Rice said the reason she became a Republican was because of discrimination against her parents. Her parents wanted to vote. Her mother was a well-educated, light-skinned woman. She got the right to vote. But when her father went up to vote, and he was a larger, darker complected man, they told him that he had to count the number of jelly beans in a bowl. And if he got that right, he could have rights to vote. Well, he was a well-connected gentleman, and he knew some people who happened to be Republicans. And they said, don't worry, we'll get you the voting right to vote. And they gave him the privilege, and from that point on, they were Republicans, and she never wavered from that because it meant so much to her. Now, this rolls into women's suffrage, because what happened in women's suffrage was the right to vote, and we're talking about the anniversary at this point, but there were two perspectives. There was the Black perspective and the white perspective. White women generally felt that if a Black woman got the right to vote, their civil rights would come along with it. Black women in the suffrage movement did not believe that. They said they needed to fight for both civil rights and the right to vote. Now, Frederick Douglass was also a big part of this, but he actually was viewed as a traitor when he sided with women's suffrage so that he could get his right to vote at the expense of Black women. Now, the 19th Amendment in 1920, and this is the centennial this year, which is why we're seeing so much published about it, gave women the right to vote, but it did not give any enforcement for Blacks in this country, even despite the amendment. So let's look at the late Representative John Lewis. We've heard a lot about him, so I'm not going to go into it too much, but I would like to say that he was a student leader. He's one of the 6 people involved in the March on Washington in 1963. And he was involved in Bloody Sunday, which was the march from Selma to Montgomery over the Montgomery Bridge that led to a riot. And you've probably seen more pictures of that than you can imagine, but it was a very painful time in our history. Now, he also was involved with the Voting Rights Act. And that was one of his proudest accomplishments. So the U.S. Voting Rights Act in 1965 gave us the right through federal government to vote both North and South, or entitled Blacks in the South to vote. Now, those of you who have followed politics know that in roughly, I believe, 2014, a case called Shelby v. Holder changed voting rights forever. And that meant that the states could change their voting policies and without federal oversight. So they could do basically whatever they wanted to. And 2016 was the first election that this ruling applied in. And 2020 will be the second. And that is why it's so controversial and so much, there's such concern about how votes will go in terms of drawing voting districts, et cetera, because there is no federal oversight despite what we've dealt with in the history. And just another fun fact, Representative Lewis served 17 terms in the U.S. House of Representatives. So we should think about that when we talk about term limits for the APA Assembly. Now, in terms of racism, there are different types of racism. There's internalized racism. One test would be where you take a pile of descriptors, say pretty, smart, handsome, healthy, fit, artistic, talented, and you take a pile of photos of people of different complexions and you have people match those word associations. That's one way that you can get internalized stereotypes to come forth. Another way is just listening to people. For example, my sister is a social worker by training, and when she was an intern, she had an African-American patient who refused to see her. This woman said she did not want a Black therapist because everything Black was bad, and she knew that she could only get good treatment from a white therapist. That is another form of internalized racism. You start to believe the negative hype about yourself or about your people or a certain group of people, just like whites can buy into it, Blacks can buy into it also. So that's the internalized. Then there's institutional racism between institutions. And basically that's a big form of it in terms of schools, colleges, hospitals, books, mass media, and they're disseminating information that supports discriminatory practices and policies. And also the policies in these institutions make it difficult for people who are other, in other words, not the majority, to advance through these systems. And you also have external interpersonal racism. And to some extent, that was what Elizabeth did to me, but more so hers was internalized based on what her brother was teaching her. And then you have structural racism, which we're looking at more these days. And I'm going to give you two different definitions of structural racism. One is a system of inequity involving the preferential treatment of the dominant group, resulting in cumulative and chronic adverse outcomes for the non-dominant group. And this is based on history, or informed by history, culture, institutions, and policies. Now, the APA has used this definition: a combination of public policies, institutional practices, social forces, ideologies, and processes that generate and perpetuate inequities among races. So basically, it's a caste system where you're using policies to limit how people could advance and what privilege they have. And people don't realize this. It's like there's I forget the author, but she talks about the privileged class where having access to a backpack of tools that they don't even realize they have, but others don't. And that's what makes it so difficult about it. It's inherent in the system, and you're saying, well, I didn't create this. So why are you blaming me for it? And it's not a matter of blaming you for it. It's a matter of looking at equity and how we can deal with these inequities. In terms of our looking at the APA, we look at the strategic initiative because that is one part of how we look at structural racism. But before that, what I'd like to say is that through the COVID crisis, we've been seeing, excuse me, let me move the slides the other way. Here we go. We've been looking at a lot of things about how Blacks, Latinx, and Native Americans have been dying at a higher rate. And so the question is, why is that? And we're going to get into that in a minute. But when we look at the APA strategic initiative, this was done in about 2015. One of the goals is advancing the integration of psychiatry and healthcare. And we've done a pretty good job of that. We keep working at that with the partnerships, et cetera, although some of it's controversial, such as nurse practitioners having equal consideration or scope of practice rights, et cetera. But we were looking at that on many levels. Supporting research, we're doing a decent job of that. Of course, with increased funding, that could get better. Supporting and increasing diversity within the APA is a true goal of part of the strategic initiative under which structural racism falls. And then there's education, which we are an educational institution. So let's move to intersectionality. It's the complex cumulative way in which the effect of multiple forms of discrimination, such as racism, sexism, classism, combine, overlap, or intersect, especially in the experiences of marginalized individuals and groups. So you can take a Latinx male who happens to be gay, who happens to be middle class. Well, how do those all interface? And how do you compare that to someone who is heterosexual, but otherwise similar in all the other classes? Each person is affected in a different way, but it's the cumulative effect. And that's what we also need to look at. Now, when we're looking at systemic and implicit bias, we know that that affects morbidity and mortality. But We also know that historically, biases were introduced to disenfranchise a class of individuals. So you used to say things like healthcare, zoning laws, nutrition services, financial mortgages, infrastructure, and how illness is defined. Those things had nothing to do with morbidity and mortality. But we now know that that's not true, and that's where systemic bias is coming to play, and we'll get into that in a minute. Now, in terms of structural racism and bias, like we said, it was previously attributed to culture or ethnicity, but this happened a couple of months ago. State Senator and physician, Dayton, Ohio physician Stephen Hudson said publicly that, quote unquote, colored people not washing their hands is a cause of higher morbidity and mortality in Blacks of COVID-19. Well, he was promptly fired from his job, but I believe he's still a state senator. And there is a cry to have him removed. He apologized for it, but you can tell certain things. A, he's out of date with terminology. Colored by some people is considered a negative term these days, but it hasn't been used in years. But why did he feel a need to say this? Did he genuinely believe it, or what was his goal? How was this edifying in any way to help us getting through this? And the subtext is Black people have bad hygiene, and that's why they're dying and getting sick at higher rates. Now, when we study intersectionality and cultural competence is a movement in medicine that looks at how the structures and policies have influenced the health outcomes. It would be like the intersectionality of healthcare. We know that that can reduce an internal and external bias and stigmatization. It increases the understanding of how systemic bias contributes to health and wealth disparities. It also supports culturally competent care, and we know that when culturally competent care occurs, outcomes improve. There are a number of studies out showing that even with culturally competent care, people are more likely to follow recommendations and get recommended treatments and screenings. And it also promotes evidence-based care. Instead of looking at whether or not someone's hygiene or alleged hygiene causes problems, you look at the evidence base to say, this is the case, this is why things are happening. And I'll give you some examples of this. When we look at algorithms in healthcare, in September of last year or October, it was discovered that there was an ER algorithm wherein if you were Black and you were white and you had the same symptoms, the Black person would be sent home and the white person would be admitted to the hospital. Then we have Roberts and Metzl, who actually pulled that in their article, Structural Competence Means Structural Racism, published in JAMA 2014. They talk about schizophrenia. Now, in DSM-2, the schizophrenia was described as an angry man, essentially, if you go and look at it. And then what the makers of Haldol did in their ad was they showed a picture of an angry Black man. And we know from study after study that even to this day, when you have a Black person and a white person with equal symptoms, the Black person is more likely to be diagnosed with a psychotic illness and treated with antipsychotics rather than depression or bipolar disorder. And the white person is more likely to be treated with antidepressants or mood stabilizers. Perhaps the DSM-2 situation is still carrying out because people don't read the book, because this is not the case in DSM-3, 4, or 5. But that ad just gives you the picture. People remember that image, angry Black man. You see the picture, you're likely to make that diagnosis. And then Dorothy Roberts also looked as a Robert Wood Johnson Fellow at renal disease. And what she discovered was she wanted to know why renal, the lab's norms were different for Blacks and whites. And she traced it back to the 1920s or 30s and found out one doctor said that at one point in time, and therefore it became dictum. And she has been on a crusade to get that change throughout hospitals. And Brigham and Women's, Mass General, I think our hospital too, have changed that. So the scores are, the cutoffs are the same. By making the cutoffs different, that means that Blacks would be referred for care for renal disease at a later stage of the illness. So the morbidity and mortality are definitely going to get worse, because you haven't caught it early. But also it makes it harder for them to be eligible for a transplant list. Why? Because the longer the illness progresses, the more organ damage you have. And then when you have a certain amount of organ damage, you're not allowed to have a transplant. So then we look at pulmonary disease. The studies show that cystic fibrosis does occur in blacks, and it takes 4 years longer to diagnose it than in whites. Why? Because of what we're taught in medical school. It's not a black person's disease. Well, while a smaller percentage of people who have it are black, it is a black person's disease as well as a white person's. And in my career, and I see people of all races, ethnicities, colors, etc., backgrounds, etc. And I've had 4 African Americans who with cystic fibrosis on my caseload during my career. And Dorothy Roberts brings out an important story where she went through a chart of an African American with cystic fibrosis. It said 4-year-old with pneumonia, 4-year-old African American child with pneumonia, 6-year-old black kid with pneumonia, 7-year-old black kid with pneumonia again. And when he's 8, a radiologist walks into the room and sees the x-ray and said, who's the kid with cystic fibrosis? When he didn't have the demographics, he saw the disease that was there all along. Again, bias. And then there are also studies about pain perception from the National Academy of Sciences, and that it's believed that blacks can tolerate more pain than whites. And they've done some nice studies that have included slides, but we're not going to go through it. And then we also have another study on burnout and residents. And this is an interesting study that was in JAMA Network Open last year. And they looked at over 3,000 non-black second-year residents. Half were male and 58% were under 30. And what they found was that stress levels were directly associated with implicit and explicit bias against black people. Now, implicit bias, they looked at using the card sort test that I talked about earlier. Happy, you match a photo. Angry, sad, untrustworthy, and you match. So they use that to look at implicit bias. And then with explicit bias, they would show people photos or tell people stories about people and use the 100-point feeling scale. And they found that there was a definite difference between how blacks were perceived and whites were perceived depending on the stress level. Now, the implicit bias was always there, but when these residents went to 3rd year and they had less stress, the explicit bias towards blacks had diminished. Now, again, we're going to look at structural racism in APA, and we talked about earlier the strategic initiative, just to whet your appetites. And we have the research, the education, and the integration of psychiatry and healthcare along with diversity. And as a member of the board, I've been involved in deliberations, et cetera. And one of the patterns I discovered was that we needed to look more closely at strategic goal number 3, supporting and increasing the diversity within APA. Because we needed to serve, it says that we need to serve the needs of evolving, diverse, and underrepresented and underserved patient populations, working to eliminate disparities in healthcare. But I realized that during my term on the Board of Trustees, we weren't doing such a great job of this, because 3 of the biggest events that occurred while I've been on the board is, number 1, moving the 2021 meeting from Hawaii to Los Angeles. The reason was money, and that people couldn't get over it. But what we didn't look at was how this fits into our strategic initiatives. Native Hawaiians are part of the diversity mission. Their needs, the patients they treat, the people who work there, etc. So they were disenfranchised in this way, which is not to say that Los Angeles doesn't have diversity, but when you think about it, they had already started preparing 10 years prior for this meeting. Number 2 was the controversy of canceling IPS in 2020. Again, money. The issue, the history of IPS shows is important in terms of the diversity of the patients it serves. People who work in community health, mental health, serve a great population of patients who are underserved, who may not be as resourceful or have the resources to be resourceful or have the options or opportunities. But also, our docs and our mental health teams who work in this environment are on the lower end of the pay scale. So they also need this meeting to have support and they use it as a networking event. They describe it as, like, some of them describe it as a family situation where you go back each year, you see similar people, you commiserate, you support, but you also learn things. And there's two sides of that, the administrative side and the clinical side. And as we know, that led to a lot of controversy. And then in the last year, at the end of Dr. Stewart's term as president, we saw diversity decampment from the APA C-suite. We had 4 APA C-suite members depart, and all were MUR members, or if you use APA's present classification of MUR. So in response to this and the fact that the DDHE, or the Division of Diversity, Health, Equity seat had sat open for, at that time, 11 months, but actually it sat open for more than a year before it was filled last week. And the person starts, Dr. James is scheduled to start next month. There was nobody overseeing diversity and health equity. And those of you who may have been on a town hall on Monday night heard Dr. Stewart say that in the late 1960s, there was an APA meeting in Florida, and Black members of the APA walked in on the meeting and said, you have to do something better. The Board of Trustees meeting, totally unexpected. And out of that came the Office of Minority Affairs, among other things, and that became the Division of Diversity of Health Equity. So this has been there for over 50 years to address these matters. And then all of a sudden, the person who's running it leaves, and there's nobody to look at this mission to make sure that consideration is given, make sure that a physician leader who monitors, works with the fellows, the resident fellow members, and the winners of Sampson Grants and Leadership Fellowships and everything, that was all under that. So this caused a lot of controversy and outrage. So in response to that, Dr. Geller in April had a meeting with members of the Black Caucus, and that was promised to them by Saul Levin after they expressed their concerns at a caucus meeting. And a couple of hours before that meeting, almost all of the other MUR groups sent letters in expressing concern about the same thing. So Dr. Geller had the meeting, he committed to doing something, and out of that came the APA Presidential Task Force on Structural Racism Throughout Psychiatry. Now, I was asked to lead it, and the one reason I agreed to was I made sure that this was not a one-year project. And I'll explain to you what Presidential Task Force means in a minute, but I want to add something because some of you have seen the controversy about the Board of Trustees and what's going on. And the one thing I admit as a Board of Trustee member is that because Dr. Geller made a commitment to do something and started to work on creating this task force, or appointing this task force, the Board of Trustees did not respond to the letters of the members. And remember, only Black Caucus, a select few Black Caucus members were in that room. And that was a gross oversight for which we regret. And that's being addressed now. Okay, so one of the things you need to know about a presidential task force is that it's different than other task force. First of all, the president can appoint a task force on anything. He has one on hospital beds right now. But the Presidential Task Force reports directly to the board. Now, they do have a level of autonomy to make recommendations to the board, and the board is not obligated to accept what they say, but they report directly to the board. They have support from APA staff to get data, collaborating information that we need to do studies and to have a scientifically, to the extent possible, scientifically informed study of what's going on, rather than just looking at emotions and responding based on that. There's member selection. The president gets to choose everybody, so we don't have a choice. And the duration of the program goes from president to president. So if next year Dr. Pender says that I still want this presidential task force to continue under my leadership, and she can appoint members and move members off, et cetera, she's free to do so. If not, it will become a committee. Now, the initial charge was providing education and resources, and you can see that on the structural racism page. Explaining the current impact of structural racism on the mental health patients, developing achievable and actionable recommendations for change to eliminate structural racism, and that's the reports and recommendations we have to provide to the board. Next one's due in the first week in October. Providing reports with specific recommendations for achievable actions and monitoring implementation. And Dr. Geller decided that in view of the current climate, he wanted to first start focusing on anti-Black racism because it's such a big charge that the thinking is that other groups will benefit from this too. The APA will benefit in generally, but it just sets a ground level for the direction in the future. And as people rotate off, other groups will be rotating on. Now, these are the members of the task force. You see a past APA president, our treasurer, the acting head of the assembly, and many other members, some members of the Black Caucus. The ethics is represented, younger people and older people. And we have worked to gel together. My goals have been that it's collaborative and member driven. You'll see the one question surveys. One of the members of the task force asked for some demographic information, but that's just to get the pulse of what's going on, because we are not allowed to distribute it to all members because the software cannot select out, and some members complain about getting too many surveys and paperwork, so we have to pick and choose. In the inaugural meeting of the town hall, the task force was announced, and this is the meeting that Dr. Geller coordinated, and he started to talk about the history of anti-Black racism, and he's done a series in Psych News on that. There was some discussion of microaggressions and their effect on professional development, anti-Black racism, Black men in law enforcement, the emotional effects of anti-Black racism, and reducing health disparities by building a community. And then this last one, which was Monday, was looking at structural racism within organized medicine, and also from the March on Washington to Black Lives Matter, including how it affects people in terms of transgenerational trauma, children and their families. The next one will be structural racism across generations, and one of the things I have asked them to do is to have a more diverse panel, because people have different perspectives about things, but it should not just be an all-Black panel. And they have some promising people that they're trying to invite to that. That'll be November 16th. And then there'll be one in February 2020, which will coincide with Black History Month, but we may also look at some things in academia and building the workforce to do the work. And also May 20, at the annual meeting, we'll discuss some stuff. Now, it's been divided into two groups. One of the groups is the Board of Trustees. What they're doing is they're looking in response to Ruth Shim's letter, and by the way, they did try to reach out to her. Jeff Geller once, Jeff Geller twice, saw Levin once, because they wanted her to consider being an advisor to the trustees, to the task force, because she had so much to offer. And they're going to be looking at how minority and underrepresented is categorized in the APA. And these are board members who have nothing to do with the task force. And they're looking at this because they realized when Jeff Geller read Dr. Shim's letter, he realized that APA had never defined this, although the assembly had. And they're also looking at the workplace culture in APA headquarters. They're hiring a consultant to look at what's going on in APA headquarters. And they recently decided also they're hiring a consultant to look at how the board functions so that we can see where the pitfalls went that resulted in these votes. What are we doing? What do we need to do differently, and what we're doing well in to build on that? The task force is divided into councils and committees. One of the the work groups are looking at governance, elected officials, and the Board of Trustees to see if there is discrimination or bias in these areas, and so what's working well and what's not, and that's going to be data driven. We have the APA staff working on getting us that data, and it's interesting. And they're also going to be looking at the assembly. Now, I talked about these two, and these are the task force work groups. Also the town hall work group, and here are some things we're looking at in the future. Scientific programs committee, publications, corrections, other MUR groups are coming in to replace some of the members in May of 2021, whether it stays as a task force or committee. And that's about it for now. I know I've given you a lot of information in a brief amount of time. I apologize for going over a bit, but thank you for your time. I'm happy to answer questions. If you have suggestions, you can send it to the SR, which is Structural Racism Task Force at psych.org. We do respond to those. And if you wanted to send something specific to me regarding the task force, it's taskforce@earthlink.net. I've already gotten 23 pages of emails in terms of if I go and look at my electronic file. So people are responding, and we encourage you to do the same. Lastly, if you have questions about racism, ask about structural racism, ask questions, especially if you see something that you don't like. And if you know it's wrong, say something. Support our residents and our colleagues so that they can have a healthier outcome to their days also, because that impacts patient care on every level. Complete the surveys that we're asking, and look at the information we're asking on the resource page, and share anything you think that could be added to that to us. Thank you so much.
Thank you so much, Dr. Wills. We are going to take questions for Dr. Wills in just a bit, but first we're going to discuss some of the things that she talked about in our breakout sessions with our moderators. So we're going to go to those now. We do encourage you to turn your video on for this part to help our moderators out, to make things easier for them. So if you do have a video camera accessible, it would be great to turn your video on for this part. And you should see the invitation to your breakout room shortly. So you can join your breakout room. And if you have any trouble getting in there, I will be in this room here. But you can go to your breakout room now. It should pop up on your screen, and there should be a join option. So everyone should be back now, I think. And if we have our three moderators, if they want to just share briefly what the highlights from their room were. I kind of hopped into a bunch of them just to make sure everything was going okay. But if you want to share some of your key points, I guess we can start with Dr. Joseph.
Okay, sure. So I think we had a pretty good discussion. One of the things that came up was when we reviewed the results from the APA task force, so finding ways to reach out to others who may not even be aware of institutional racism. And one was that we should try to find ways of having conversations with groups that don't commonly have these discussions. Some residency programs are having weekly reflection sessions where they discuss racism weekly, so where it's something that is scheduled and kind of makes it more comfortable, especially if it's emphasized by the leadership, to where people will be more inclined to kind of fall in with everyone else and go. The other thing was that we noticed a lot of the hashtags that are commonly used, like BLM or Black Lives Matters, and how that can really kind of limit who might be seeing it, with some consideration of adopt or adding on other hashtags that may belong to different groups, so that our information might also kind of come across their feeds. And then we also talked about with leadership, when we appoint people to lead diversity and inclusion, just to make sure that we are taking into account the opinions of those groups that are affected. So when we're appointing people for diversity, making sure that we are listening to our minority and underrepresented groups to take in their opinion on those positions.
Dr. Martin, do you want to share what was going on in your group?
Yep. So we talked about the importance of knowing like when to reflect and when to act. We also talked about the survey and how part of it was a good thing that people felt comfortable enough like to say that they didn't think there was systemic racism. So at least now we're aware that that is an issue and we can begin addressing it, versus if everyone had said it's not like it is a huge issue, then maybe we wouldn't need a task force. So it's like kind of a blessing in disguise that people were like that honest with us. The importance of like spreading the work when it comes to diversity and inclusion, and making sure that the work doesn't just fall on like minorities. We talked about bias and recruitment and some strategies to like maybe eliminate bias from that. And then just maintaining community to prevent burnout and wellness and helping to support retention.
Awesome. It sounds like you covered a lot. And we have group 3.
Hi, how are you? Yeah, so honestly, everybody kind of covered a lot of what we discussed as well, but just some points, some additional points. I think that our group was quite surprised when we talked about the APA task force and the amount of people that actually did not think that there was any institutional racism at the APA. And so that was very surprising for our group. We also talked about some of the changes that were happening at the institutional level. Somebody talked about the using the everyday discrimination scale with some of the residents in the training. And also we talked about just getting your colleagues and staff to recognize implicit bias. That would be like a starting point. We also talked about the difficulty sometimes with talking about race with colleagues. So some people are having these weekly discussions, and then, you know, other people are not having them as often as they would like. And somebody actually shared a really nice or a very important story that they had with an intern in a stairwell that we kind of delved into a little bit more as a group.
Thanks. So I know we have a couple of minutes left for some questions for Dr. Wills. So if you would like to use the raise hand function under the participant tab, we can do it that way. If you have a question for Dr. Wills after the breakout discussion, anything lingering in your mind, would be great to ask it now. And we can start with one, Dr. Wills, that we got in advance of tonight, which was that a lot of the initiatives often seem to focus on trainees, but most psychiatrists obviously are not trainees. They're past that point. So how do we effectively address those people who are not in training programs?
Or in terms of academic medicine, or all of the above?
I think the question was focused on institutions because they were saying a lot of resources at their institution was directed at the residency training program, but not necessarily at the kind of more seasoned doctors.
You're absolutely right, and that's a problem. You know, one of the things, if you were attended the task force, the first town hall, and you heard Thea James, I really, really wanted her to be there because I think what they're doing at Boston Medical Center is outstanding. And she was the last speaker, so you can fast forward to her if you want. But one of the things they do is that they actually have a structural competence training curriculum. Before any resident or attending or medical student touches a patient, they have to do that as part of the orientation. And it explains things like redlining, housing discrimination, food deserts, etc., so that at least they have that background before they touch the patient, because it may ring a bell and help them to understand better the patient.
Be how it is for quite some time.
Oh, absolutely. Dr. Geller's mission was to start with Blacks, and I was concerned about that. And one of the reasons I agreed to continue it, I said, you can't stop here. If you want to choose all Black members, I thought, Native Americans are even worse off than Blacks. Could you at least appoint a Native American to get that perspective? But they agreed that over time, this is not going to stop at year one. This is going to go on either as a presidential task force, or if the president does not want to continue it, as the next president doesn't want to continue it as a presidential task force, it'll become a committee under one of the councils. So this is going to go on. But also note that our subject matter experts on structural racism in Black involving Blacks. Two of the subject matter experts are white. One of them is your very own, NUIU's very own Hunter Misquiston, and he's brilliant. He comes up with some insights and introspection that is really bringing in thoughtful ways to approach this matter that maybe others haven't occurred from. Very creative, and is very committed. The other one is Renee Bender, who actually took the Board of Trustees, when she was president of APA, took the Board of Trustees on a field trip to San Quentin Prison. And she's very invested in corrections and bias and such. You know, picture the board and picture them all touring a prison. Now, I don't know what other president could pull that off. So we have those members too, but he does want it to be half board members and half subject matter experts. The addition of Charles Dike was done when I realized that I'm not going to be able to contribute at the level I want because there's so many, I have my hands in so many different places. He's an ethicist. He runs a correctional hospital in Connecticut, but he's also Nigerian and came here for his medical education or postgraduate medical education. And he said when he came here, he thought that racism didn't exist. He said, you've got to be, structural racism doesn't exist, it's a bias. You have got to be out of your mind. Nobody would have that here. And I've heard that from other people who are treating Blacks in different mindsets, even when white doctors have tried to have the talk with kids of Black patients because they're doing dangerous things like running across a multi-million-dollar home lawn in a wealthy part of California, which is, you know, putting yourself in danger zone. And the parents are saying, no, we're raising our children in a race-free society. But what Dr. Deacon said was, I thought there wasn't, but after about 2 years here, I said, there's something to this. And each year I stay here longer, I see more and more of it, but I didn't want to believe it. So subject matter experts of all types are needed. And be on a task force. That doesn't mean that you can't advise or inform us. Use those emails. Create your own projects. Don't sit still. While this is a hot topic, this is your opportunity to get things started, get things rolling, and your take on it will be very different from my take or the next person's take. Remember, the task force has a consensus take. It's not what I want or any of the other 10 members want. It's what we agree on as a group, and the same thing with the Board of Trustees. You may say a position, you may not like the outcome, but you have to support that outcome as a group, but you do have your say in it. So we're not going to cover everything. That is highly unrealistic, but let this be a springboard for you to say, you know what would I like to do?
Thank you so much, Dr. Wills. And we're just about out of time. I wanted to thank everyone who's participated and to let you know that we will continue these once a month. And hopefully you'll get to join us again next month. So thank you all.